My name's Dr. Morgan. I'm the Trust Clinical Audit Lead, and this presentation on clinical audit is to enable trainees to become familiar with the process with which they'll be involved. Right, who we are and where we are. As I've said, my name is Dr. Morgan. I'm the Clinical Audit Lead for the Trust. That is from the medical perspective. There is a Clinical Improvement Manager, a Clinical Audit Manager, 3 Clinical Audit Facilitators, and we all reside in the Clinical Quality Centre, first floor offices above the new main entrance. Okay, clinical audit. What's clinical audit? Often misunderstood, and it's important to get the definitions right at the very start. In simple summary, it's an evaluation of local performance against established and locally agreed standards of care in any particular service scenario. To be a little bit more explicit, clinical audit's been defined as a quality improvement process that seeks to improve patient care against explicit criteria and the implementation of change. The key points being explicit criteria, standards, with the intention of implementing change if it's found that those standards are not being met. There is no point undertaking clinical audit against standards that you know, A, you don't even profess to provide within your organisation, and B, if there is no will to implement change as a result of the results of your audit. Aspects of the structure, processes and outcomes of care are selected and systematically evaluated against explicit criteria, again, where indicated changes are implemented, again, at an individual, team or service level, and further monitoring is used to confirm improvement in healthcare delivery. So that's an expanded version of the previous slide, and that was defined by NICE in 2002, and it's basically what we try and run with in terms of designating projects as clinical audit pieces of work. Clinical audit's often represented as a cyclical process. We won't go through every single one of these particular points, but basically you have an area of service provision that lends itself to audit. That may have been prompted for a range of different reasons. In the first instance, you need to identify best practice, establish your agreed standards, make sure that those criteria are agreed by all participants and those that might be affected by your project. And then you need to submit the completed audit proposal form, which we will go over in some more detail later on. There's a period of data collection, a period of data analysis, and then a presentation of your findings at either departmental or divisional level. Following that, an action plan should be agreed by those who have the capacity to deploy resources. So that wouldn't necessarily fall to you as trainees to follow through with, although occasionally you'll be involved in that process depending on your recommendations as a result of the findings of your audit. And then to round off the cycle, a full formal report ideally is then written. A completion form is mandatory, which includes details of the action plan, together with target dates for implementation of specific actions. And then to complete the cycle again, or fully, you would undertake to re-audit in that service area at an agreed interval to establish that your recommendations and agreed actions have been implemented and that ideally service has improved. Okay, just a quick slide to differentiate between multidisciplinary and cross-speciality audit. Multidisciplinary means between doctors, nurses, physiotherapists, etc., the whole team auditing any aspect of service provision within or between divisions, departments or specialities. So Everybody mixed together, not just medical, not just nursing, not just allied healthcare professional. Whereas cross-speciality is any mix of team members auditing an aspect of service provision between divisions, departments or specialities. For example, fractured neck or femur. The care pathway includes medical, nursing and adult healthcare professional staff in A&E, orthopaedics, anaesthetics and theatre. That is clearly cross-speciality rather than purely cross-disciplinary doctors and nurses. This is perhaps the most important slide. What is not clinical audit? The last thing that you want to do when you've submitted your proposal for audit is for us within the clinical audit review panel to look at the proposal and come back to you and say, actually, this is a service evaluation, or this is a census, or this is the soft clinical research, etc. So it's really important to make sure that when you submit your proposal, it doesn't fall into any of these categories. Comparison of treatments or interventions, that really is research to define best practice. Outcomes of new treatments, that's again research. Outcomes of new service developments, pure research as stated, or service evaluations where you look at what is happening in a given service area of provision in order to decide what you think should be happening. Consultation between seniors with reference to established good practice. That then generates standards against which you may conduct pure audit. But in the first instance, looking at what we're doing is really service evaluation. Census work and just pure measurement of throughput and activity, none of those fall under the designation of clinical audit as understood in this trust. This just again underlines the difference between audit, research or service evaluation. Research aims to evaluate and define best practice. That's a nice easy phrase to keep in your heads if you're trying to work out exactly where your quality project is fitting in. Service evaluation aims to evaluate and critically appraise current service provision, i.e. what is it exactly we're doing and perhaps what are the outcomes. Audit aims to evaluate how close local practice is to agreed best practice, i.e. you must have agreed local standards that you aspire to within your organisation for this particular aspect of service provision, and it's that you measure performance against. I'm hoping that that is now clear. Why do you need to get engaged in clinical audit? Well, it's a clinical governance requirement for the trust at corporate level, divisional level, departmental level and speciality level. For yourselves, it's a training requirement. My understanding is that you're required to do 2 quality-related projects per year, of which clinical audit, as an example, and service evaluation is an equally relevant example from the point of view of your portfolios. Clinical audit is an appraisal and revalidation requirement for consultants and non-consultant career grade staff, so-called continuing professional development. The bottom line is really, I guess, that which should be driving us to participate in this, is that it's a potentially powerful instrument for the maintenance of and improvement in standards of clinical service provision. So what do you need to do? You need to speak to the clinical audit lead within your division or speciality, and you need to do that soon, because you'll find that with the best will in the world, things take time and you only have a limited time to work on these projects. Having spoken with your clinical audit lead and perhaps having been directed towards an auditable topic, you then come and speak to the clinical audit staff in the department. Identify your team of auditors, including the senior supervisor. Now, your senior supervisor may be a consultant with an audit interest who has put you onto the project in the first place. However, we require a clear indication of your senior supervisor so that as you move to and fro in your training, we can still track progress with the consequences of your audit and recommendations. Having done that, you then complete the audit proposal form. We're on to version 6, which has served us fairly well, but even with version 6 there will be revisions and perhaps a little streamlining and tidying up, but for now that's what you'll work with. You need to identify what the aims and objectives of your project are, what the relevant standards are, and what your target compliance with those standards might be. Sometimes it's implicit that standards will be 100% target. Sometimes that may not be the case if there are national figures to suggest that a given level of compliance at X% is a reasonable target to aim for. That may be included, but the majority of standards, the implicit target is 100% compliance. Completing the proposal form of version 6. This can be found on the Clinical Audit SharePoint site on the intranet Trust homepage. If you need any help completing the form, then just call into the department. As I've said, a consultant must be named as the lead auditor, senior supervisor. Now that is different than you as the lead auditor on the ground collecting data. So that's an important distinction. It isn't expected that the senior supervisor is necessarily named as the audit lead. You need to make sure that all sections of the form are completed. If you fail to complete all sections, it's likely to cause delay in the approval of your audit. You shouldn't start data collection on your project until approval from the audit department has been received. The audit form must be signed by the speciality audit lead, not the lead auditor for the project, although they could be one and the same in theory. The proposal form then needs to be taken to the clinical audit department, hard copy, not electronic, along with the guidelines and standards against which you're auditing, and a copy of your data collection pro forma. We will help you constructing your data collection pro forma if that which you present could be improved upon. You need to wait for confirmation that your audit has been approved before beginning data collection. I would like to be able to guarantee you a response within a week. It does depend on other work pressures. We do get to them as soon as we can. Clinical Audit Proposal Form, version 6. I'm not sure how well you'll be able necessarily to read these, but it will give you a feel for the layout of the document, and I'll comment on it as we work through. This is page 1. The top section requires that you indicate the division or speciality or department that you're in. Your name down then as the audit lead with either a telephone or bleep extension, an email address, and the name of the senior supervisor with their contact information. Then an indication whether it's a new audit, a pre-audit, which is only very slightly different than service evaluation, or whether it is a re-audit. Now there is a prioritization process recommended by HQIP that allows us to grade audit proposals 1, 2, 3 or 4 in terms of priority. 1 and 2 are mandatory effectively, either as a result of the Trust's expressed strategic aims or audit activity that's imposed on us from the outside with which we have to comply. The majority of those with which you'll be involved are likely to be priority 3, which is speciality driven. We don't register many priority 4s. They are individually driven, an individual's clinician's personal interest, and I don't think we really have the resources to undertake that. So most of them are going to be priorities 1, 2 or 3. We then want you to return or provide reference to whatever documentation or speciality organisation from which you've derived your standards. So you'll see that there is a request that you put in, whether it is NICE, whether it's CQC, whether it's Royal Colleges, Literature Search, NHSLA. Now sometimes those documents are very long. Guidelines on good practice from NICE, for example, may easily run to tens of pages. What we would want in that situation is that for you to just take out the page or pages from which you've derived your standards, print them off and include them in the documentation. There is then a section for you to put the title of your audit in and the objectives. They need to be summarised in simple terms. I would advise against you putting aspects of cost improvement, service evaluation in your descriptive, because it'll just bounce if you do that. We then require some dates when you plan to start, when it's to be completed by, when the presentation at your speciality area or your divisional audit meeting might be anticipated, and when it's completed, that is to the point of delivery of a completion form with an action plan. We need to know how big your sample size might be, or the dates between which you're collecting data. And we also need to indicate whether or not there's patient and public involvement. My experience is that that isn't a particularly common phenomenon. Okay, press on. It's very helpful if you're auditing across the trust to make sure that areas that you don't personally work in but that might have an impact on the service being audited are aware that the audit's being undertaken. So we request at least that you indicate areas that will be affected other than your own speciality area. We then need you to put down your full audit team. That includes the senior supervisor as well as the auditors. And there's an opportunity there for you to put contact information down. We then require that you indicate what resource implications there will be for the clinical audit department. We will assist you in the preparation of your data collection pro forma, and we will assist you in securing case notes. We don't help you construct databases these days. Most of the time people use a simple spreadsheet, and the majority are familiar with Excel or can find access to somebody who can help you with that. We will provide some advice on the way in which a report might be finally completed along with a case note, along with a template, sorry. The next two sections relate to the impact of this particular project on various aspects of trust collectible information. That is, whether there is a risk to the organisation, a risk to the individual patient, whether this is driven by assisting patients with long-term conditions, whether it's driven by safety in patient care. Those are the next two sections. Then it needs to be signed by yourself, signed by your clinical audit lead in the speciality, and if this is a level 3 project, that's a new level 3 project within the given audit year, we also require that the divisional director be aware that it's being added to the clinical audit work plan that's already been approved. The grey section at the bottom is for me to complete, indicating where you're up to with the process, whether your proposal has been accepted. If it has been accepted, then there will be an approval date and it will go on to the clinical audit work plan. If it hasn't been accepted, it will say why not and what date we contacted you, and then subsequently when it's finally signed off. There is a section and the proposal form that asks you to detail percent compliance with your standards, target compliance with the given standards. And then what else do you need to do having completed the proposal form? Well, if you require case notes, the patient list can be passed to the audit manager, that is the clinical audit manager, Jane Porter at present. If you don't already have a patient list, then advise the clinical audit manager of the patient group, the diagnostic group, and a list will be requested on your behalf. I should point out that not all audits require case note reviews, and some of them can be done prospectively, in inverted commas, as patients come through the system. Once the case notes are available, if that's what you need to use, begin your data collection and do your very best to complete that within the target for completion as recorded on the proposal form. If you can't complete it within the target time, we do at least need to know within the clinical audit department where you're up to, and we will chase you if things appear to go on without progress. Time goes on without any clear progress. When data collection is complete, you need to inform the clinical audit department. Analyse the data and develop your personal presentation. Present your findings at divisional or speciality or both meetings. Having presented that, we would expect your presentation to include some recommendations. The relevant divisional director or head of department eventually will then need to sign off an action plan which may or may not include your recommendations. They need to identify who's to be responsible for implementing each of the changes and by when. You may or may not be involved in the process of facilitating the development of the actual action plan, but in terms of your personal commitment as a trainee, it goes up to the point at which you make your presentation with recommendations. You then send a copy of the report, presentation of your audit, to your audit facilitator along with those recommendations. From that, we can give you a certificate to confirm participation, and if you do need their certificate, please ask your designated facilitator and they'll organise this for you. Certificates do require that I look in detail at the audit, its findings and recommendations, so they do take just a little while to put together. There is no point just signing off participation without indicating your findings. If you find yourself subsequently in an interview or a portfolio review for progress, it will be helpful if those with whom you're meeting at that time can visually see the results of what you did against the standards that you chose to audit against. Please try and be clear in your heads what is audit and what is service evaluation. If you get that wrong, it won't help in your interviews when you might discuss these projects. Remember that there are hundreds of audits on the work plan, all of which we have to keep track on. You've only got one, so please keep the audit department updated and make sure you complete the full audit cycle, at least to the point of presentation of your results and recommendations. You can get additional information from the clinical audit department, from the Trust intranet document library under audit. Corp Proc 561 undertaking clinical audit will give you all the details really that you should need. We can provide templates for presentations and reports. There is one thing before I wish you good luck in your project work. If you do get behind, then we have what's called an escalation process. If you fail to meet your targets for completion of data collection, presentation, etc., then your audit assigned facilitator will chase you for further information. If that isn't forthcoming, then we would go to your senior supervisor, and it continues on from there up to and including the medical director if we can't make progress or can't find out where a given project's up to. But of course you're not going to do that. So again, I wish you good luck with all your endeavours, and remember, anything that you're not clear about, just come and ask us. Happy to take some time out. It saves an enormous amount of time in the conduct of your projects if the paperwork and documentation is sorted out properly at the start. Thank you very much.